asking our community-based organization partners at different countries to share how they have thought of innovative ways to deliver HIV services despite the interruptions that has been caused by COVID-19 pandemic and government lockdowns. And then we would be inviting Michael Castle from Linkages and Epic Projects to share what are the ways forward or the strategic considerations in moving forward considering COVID-19, particularly in delivering HIV services. So without further ado, let's invite Anna from International AIDS Society to discuss the impacts of COVID-19 on HIV service delivery. Anna?
Great. Can you hear me, Anad? Okay, so hello everyone. As mentioned, my name is Dr. Anna Grimsrud and I'm the lead technical advisor at the International AIDS Society. I want to thank APCOM for the opportunity to present with Linkages, and thank you all for taking time on your Friday afternoons. I'm dialing in from South Africa today, and I know that many of the examples I have here are from the region and sub-Saharan Africa, but I really look forward to learning from all of you about innovations in Asia and the Pacific region. So in the next 10 minutes, I'm going to go through a number of slides, but I'm sure that APCOM will make the slides available later, and I've put in a lot of hyperlinks to resources for you all to read more, so please stick with me. So the presentation today is going to be on the impacts of COVID on HIV service delivery, and I'm going to share some of this data, but I also want us to know that we're still learning what the full impact will be. And so while the focus of all of our work is on ensuring there are minimal disruptions and treatment interruptions, I really want to highlight how differentiated service delivery is being leveraged and adapted at this time to make sure that we're reaching people with services, and the key role that community-based organizations are playing and should continue to play in the response to HIV during this time. So the project that I lead focuses on differentiated service delivery, or DSD, a concept that was defined in the past 5 years in response to the WHO guidance to treat all, and in recognizing that a one-size-fits-all approach to service delivery is not going to be sufficient if we're going to reach our targets, and it certainly wasn't going to be sufficient if we were going to be client-centered. And so while COVID-19 may be unprecedented, it's really not unprecedented for services to be adapted and DSD to be expedited in times of emergency. We see examples of this from Guinea and Sierra Leone in 2014 and 15 in response to the Ebola outbreak, and also in the Central African Republic, where 6-month refills were distributed by lay healthcare workers in 2015 during times of conflict. And most recently, we've seen a response in northern Mozambique to conflict where mobile clinics known as brigades have been introduced to ensure uninterrupted treatment. So within differentiated service delivery, we talk a lot about these building blocks, or the who, what, where, and when of service delivery. So COVID has really pushed us, and in some ways provided us opportunities to change the when by reducing the frequency of visits to healthcare facilities, by changing the where by enabling services that can be decentralized to community, by changing the who by increasing the role of task sharing and peers, and by changing the what by encouraging us to have more integrated care and really wrap around services and how we can better provide services on virtual platforms. So first, I really want to talk about the realities around supply chain, because this is critical for us in terms of understanding how we ensure uninterrupted access to antiretroviral therapy. So there are strong global efforts by partners at WHO, Global Fund, USAID, and others to ensure there are minimal interruptions. And when we talk about supply chain challenges, we really need to look at the many layers. So we were initially concerned about API production in China, or the raw materials that we use in order to make antiretroviral therapy. And then we became more concerned about some of the manufacturing challenges that were going to be the reality as a result of lockdown in India. And now we're also dealing with some of the logistical challenges around transportation of antiretroviral therapy, and learning that many of our passenger flights were shipping a large proportion of our global cargo. And I think the supply chain challenges we see are indicative of other challenges with COVID, and that some of them are new challenges, some of them are exacerbated existing challenges, and some of us are reminding us that we needed to do better even before the COVID outbreak. So in terms of data on the impact of COVID on service delivery, we can look to some of the WHO data when they surveyed 84 countries between April and June of 2020 this year. And they found, as shown on left, that 24 countries, the ones in the orange, had 3 months or less of first-line antiretroviral therapy in stock. And 73 countries reported a disruption of ARVs in varying degrees. On the right, you'll see the percentage at risk of having an interruption by WHO region. And causes that were cited included drug supply and manufacture shutdown, health system capacity constraints, access to services and financial constraints, and restriction of movement because of lockdown. In this map, you'll see the red countries reported having an ARV disruption of some kind in this time period. And it really highlights this is not a challenge unique to one region, but a global challenge. We've also heard a lot about ARV interruptions, and many of you will know about this well-cited modeling work that was just published in the Lancet HIV that highlighted if there was a 6-month total disruption in treatment in sub-Saharan Africa, there would be an increase in mortality and an increase in transmissions via PMT-CT, and this could lead to an additional 500,000 deaths. But just to alleviate some of that fear, the authors said that they don't expect this to happen. It was just modeling of scenarios. And I'll refer you to this quote here, which says that essentially all models are wrong, but some are useful. And so that leads me to what I really want to talk to you all about today, which is the 5 key takeaways about how COVID-19 can actually push all of us to provide client-centered differentiated service delivery and ensure quality care, perhaps both during and beyond COVID. So how are we going to be this positive change? So first, we must expand access to DSD for people on treatment, and we've seen this happen. Models have traditionally been reserved for clients who've been on treatment for more than a year and who have a documented suppressed viral load and those who are over a certain age. But now we're seeing the changes to the clinical criteria and more of an inclusive approach for all populations. So this includes pregnant and breastfeeding women, adolescents, and key populations. And in an ongoing review, we see that this eligibility criteria has changed in at least 15 countries in sub-Saharan Africa as a result of COVID, ensuring more people have access to the services they need. Secondly, we need to prioritize community-based and out-of-facility services. And this we can do by separating clinical visits from ART refills. Many countries have promoted an acceleration of community models in response to COVID. And these community models we can divide into 2 buckets: client-managed groups, commonly known as CAGs, or what we call out-of-facility individual models that others refer to as decentralized drug distribution. And these models include community pickup points, which could be things like community pharmacies or collection from CBO venues, or other venues like places of worship. They also include key population drop-in centers, private pharmacies, mobile clinics, and in some cases, home delivery. And there are many examples of this from all over the world. And I've kind of tried to include a variety here, including both these home delivery, these community pickup points, and really getting us to think differently about how we provide solutions. The third point is that we really need to integrate or strive for wraparound services. And so if a person living with HIV also requires TB preventive therapy or also needs contraceptive care, we need to ensure these refills are aligned with ART. So the benefits of DSD for HIV won't be realized unless we recognize the needs of the client holistically. So for example, in Eswatini, India, Uganda, and Zambia, there are further efforts to integrate during the period of COVID-19. Fourth, and perhaps most well known, is that we need to increase both the duration of ART prescriptions and of ART refills. So the WHO recommends 3 to 6 months of ART for all clinically stable clients. And there's been a huge push to ensure that people have a longer supply on hand during the pandemic. In South Africa, we've seen that during COVID, there's been permission for prescriptions to be extended to 12 months so that we can allow for community dispensing of ART in between clinical consultations. And in this WHO slide, you'll see that many countries do have policy that allows for multi-month dispensing. Navy blue here is 3 months of multi-month dispensing. Very few in green allow 6 months, and there's still progress for the light blue and the gray countries. And this is policy again, which may need support in terms of ensuring implementation is happening. Last but not least, we need to ensure that these DSD principles are applied also to PrEP delivery, to HIV testing, and to initiation. And so in regards to PrEP, we've really seen COVID-19 catalyze the demedicalization of PrEP and change the building blocks, with PrEP refills extended and offered via community venues. For example, in some of the work presented at the AIDS 2020 virtual conference, there was an example shared from the Princess PrEP program in Thailand, where PrEP prescriptions and refills have been extended. There's been increased support via telehealth, and there is support for self-screening and self-sampling, both for HIV and STIs. For testing, we need to look at how we better utilize HIV self-testing, including within health facilities, and how we support safe community testing with strong linkages to same-day treatment initiation, as well as encouraging those who are not yet on START to start. And so, in closing, COVID-19 has had some silver linings for enabling service delivery adaptations to HIV. And we must take this opportunity to pause and think about which of these adaptations could and should be sustained and supported going forward. As is stated in this slide, in the rush to return to normal, consider which parts of normal are worth rushing back to. And so with that, I thank you and invite you to come to our website, differentiatedservicedelivery.org. You'll see a COVID-specific page there where we have the latest WHO, PEPFAR Global Fund guidance, as well as guidance from partners such as EPIC on how they're providing services during COVID. And we'd also really like for you to get in touch and share your work with us so that we can increase our understanding and knowledge and shine a spotlight on all the work being done in the Asia and Pacific region. Thanks very much.
Thank you, Anna. If you hear any sounds from our background, that's because we are having a strong rain at the moment here in Bangkok. But I would like to highlight Anna's presentation on the map. If you caught the map, there where she pointed out the restrictions, mobility, and disruptions to HIV and ARV drug supplies. We can see that there's a lot of red spots in Asia and the Pacific. And also, I recall the calling for the advocacy or advocating for community models or out-of-facility dispensing of ART, particularly multi-month dispensing. So we are not only looking at innovative solutions like community-based organizations, but also how do we advocate to make sure the HIV programming actually responds to the current situation. Thank you so much, Anna, from the International AIDS Society. We now proceed to Australian Federation of AIDS Organization, or AFAO, International Program, Dr. Fatim, who will be presenting some of the findings that AFAO did in the recent months on the effect of COVID-19 community-based organizations in the region. Dr. Fatim?
Hi, shall I share my screen?
Yes, please.
Okay. Is it sharing it? Can you see it?
No, not yet.
Oh, 1 second. It's trying. Oh no. Okay. Can you share that?
Oh yeah.
Yeah.
Yep.
You okay?
Yep. Please go ahead.
Okay. So thank you, everybody. Good afternoon. My name's Fatim, and I work at London School of Hygiene Tropical Medicine, and I also support FAO with some of their work, including, as Inad just told us, reviewing the potential impact of COVID-19 on their work programs during the initial crisis response period. So thank you very much to APCOM for the opportunity to present this piece of work that I help them with. How do I change my slide? Sorry. Okay. So FAO's in FAO, for those that don't know, FAO in the Skipper program, FAO is an Australian non-profit organisation, and it provides leadership, coordination and support to the policy and advocacy response to HIV in Australia and Asia. Its international arm leads on the Skipper programme, where the goal is to promote sustainable services for key populations at scale to stop HIV transmission and AIDS-related deaths by 2030 in 8 countries in Asia Pacific. And we work with many community-based organisations in the region, as is shown here. My talk today is about trying to understand the challenges and opportunities for community-based organisations during the initial crisis response phase of the COVID-19 pandemic. SARS coronavirus 2 pandemic, it's a catastrophic global health crisis, as we all know, and now with far-reaching social, economic, political consequences. It's had an unprecedented impact on society, both directly and indirectly, and it's led to a widening of inequalities and compromising the lives of millions. Recognizing this, and that the indirect consequences were likely to be disproportionately felt amongst the most vulnerable populations, such as those served by our Skipper program. As countries in Asia Pacific and Southeast Asia went into lockdown, what we did was at Skipper and FAO, we sought to understand the situation in each of our 8 countries, the challenges to service delivery, the impacts on ongoing operations by the community-based organizations, and opportunities for alternative ways of working, delivery and access, so we could then help them to address any of the collateral impacts of COVID-19 and support them. So as Peter Sand said, if we don't act decisively, we risk giving up years of hard-won gains in the fight against HIV. So to that, we undertook a review. So this comprised of a desktop review of each of the countries' situation and their statistics at the time. We took a questionnaire survey from each of our implementation partners, and also we just had, in the past few weeks prior to undertaking this review, we'd had a number of webinars had been held between 9th and 22nd April with the community-based organizations, and we discussed at those, knowing that we were going to be doing this review, we discussed the challenges, mitigation strategies and opportunities presented. So this presentation is very much talking to the initial few months as the pandemic evolved from January to April, but it still applies as now, obviously. So the situation analysis found that all Skipper countries had intensive containment measures in place. Bhutan was the only country to be in partial lockdown at the time, whilst the remaining 7 Skipper countries had been in full lockdown for varying amounts of time, ranging from end January for Mongolia to end March, PNG, that's when for Papua New Guinea, Laos and Malaysia, they'd gone into full lockdown in March. So these restrictions had reduced HIV service provision significantly for the key populations, primarily due to reduced staffing, because many staff had been redeployed to help with the COVID-19 response, and also therefore reduced clinic hours, and in some cases, as the previous speaker just spoke to, reduced resources in the form of test kits, medicine supplies, etc., all secondary to problems with supply chains and logistics, as we just heard. And then there was also closure of all the entertainment venues and other workplaces, and this had limited the outreach clinics that were available. So and another thing that we found is our implementation partners in Sri Lanka were telling us that many of their key population members were very reluctant in many cases to access services, because if they left home, they had to have a reason and they had to have a curfew pass, and in so doing, they had to disclose their status, making it very difficult for them. So, next slide, sorry. So our delivery partners told us, and community-based organizations told us, that during this immediate crisis period, during this immediate crisis period, containment measures had severely restricted mobility, and hence all face-to-face activities had been suspended for the duration. And working from home had been implemented wherever feasible. So pretty much everybody was working at home, apart from finance teams who were allowed to access the office, but only 1 time per week for a limited period of time. All face-to-face consultations had been suspended, and many of the organizations were very concerned that they might need to take on a much higher share of the common operational costs, because government money now was being redirected towards the COVID-19 response. And they were really worried about how they were going to afford additional costs incurred, like ensuring safety of their staff, of their communities by sanitizers, PPE, disinfectants, and also shuttle buses for their staff, because they had to safely and legally get them backwards and forwards. Many staff were spending the time just living in the office in order to try and make services remain open. One of the biggest challenges that was identified was the limitation of IT networks and capability, both hardware, software, and IT skills. In almost half of our skipper countries, including Sri Lanka, Timor-Leste, Papua New Guinea, there's very limited access to IT structures, be it that staff have to share a desktop at work, they have nothing at home in the sense of laptops or internet access. Also, the communities may not have appropriate internet access either to be able to access services if they're being done remotely. So many, many challenges, but despite these challenges, they were very positive, and the organizations were really quick to initiate, we found, a number of mitigation strategies, including developing health and safety protocols, supporting other community organizations who didn't have easy access to IT and virtual platforms to try and learn where the best ones were, how to source them, how to access this. Everybody moved to online working wherever it was feasible, and everybody was contributing to the national COVID response at the same time. Many of the regional networks undertook very quickly rapid anonymous surveys in order to better understand the needs of their populations. Youth Lead, for example, found that young key populations and young people living with HIV were experiencing significantly more difficulties with access to services, and in some countries also to ARVs. In response to that, they set up an emergency relief fund and established that to support the relief efforts on issues related to their populations. APCOM here, thank you very much, developed health, safety and wellbeing protocols for their staff, and then shared these amongst each other. And this was one of the key strengths, was that there was so much more time because of not traveling and being in one place, not even necessarily being able to leave your home, to be on your internet and at every meeting, that we were able to collaborate and strengthen relationships and understand how not to duplicate. So instead of developing 12 sets of health and safety and wellbeing protocols, it was just one, and this was being shared amongst everybody. Organizations with access to virtual platforms, especially social media, also took the opportunity to design and promote innovative service delivery and communication options via virtual platforms. This included things like hotlines, concerts, home deliveries, using other services like motorcycle drivers who no longer had a job because everybody was in lockdown, to then help to deliver medicines. One such organization is Love Yourself, and I know that they're speaking next, so therefore I'm going to leave it to them to talk about all their amazing initiatives that they were excellent initiatives that they did in those first few months and continue to do now. And I think many of these icons which I've taken from them and demonstrate how much work they've been doing. Another organization, just as a case study, is in Sri Lanka, who had very strict lockdowns, and the community-based organizations there did similarly, in that they set up emergency funds where the general public could then donate funds, which were then directly transferred to those who were identified via the community-based organizations and their trusted networks as being in need. And this was essential and critical for many people, because what we were hearing was that you can't concentrate on your HIV care and your medical care and your health care if you simply can't survive. Whether if you can't have food and you can't have shelter, then it's not going to work for them. So in conclusion, what came across very clearly from our study was the significant difficulties that community-based organizations, our implementation partners, and the communities that they served have been facing and continue to face. Many of the countries are still continuing to move in and out of lockdown, and containment has made it really hard to engage, organize activities, and ensure access. Yet it was very impressive to hear how organizations had demonstrated such resilience in identifying many alternative ways to exchange information and deliver their programs within the given constraints, to support the pandemic response at the same time, and to also explore digital platforms to engage with their communities. And it was really nice, it was really exciting to hear them voice their feelings of empowerment despite the numerous challenges that were being faced. And as the previous speaker said, I think it's really important that when we go backwards or forwards to our new normal, that we maintain many of these new initiatives that have come about, and learn that perhaps there was things that we've done so much better now as well. At the same time, however, it was very clear that there are significant inequities in the responses and abilities to both sustain services and take advantage of the opportunities to innovate. Primarily, and what came across was it was very much dependent to what technical capacity there was within countries and CSOs in their IT abilities and their IT access. So that's mine. That's it. I'd like to especially acknowledge all our implementation partners who helped to give us all this information, and thank you very much. And that's it. And there we go. Thank you.
Thank you, Dr. Patton from AFAO. So the SKPA countries that she mentioned are the countries which are supported by the Global Fund Technology Program for the sustainability of the population HIV services. So these are Bhutan, Laos, Papua New Guinea, Philippines, Mongolia, Sri Lanka, Timor-Leste, and Malaysia. And Dr. Patton has clearly highlighted that there is a challenge to mobility, which kind of like made a burden for the common operational costs of community-based organizations, and shifting the needs also of the key populations to basic needs such as food and shelter. And she mentioned about the limitation of IT capacity of organizations, but catching up to make sure that we have access to the latest information on the internet. Now, we are still working on our Facebook Live. We will be live shortly in Facebook, but we are also live tweeting our webinar on Twitter. So make sure to check out our Twitter page as well. That's at APCOM. Now that we have understood the impacts of COVID-19 to HIV service delivery, particularly the disruptions on the supply of ART or the antiretroviral treatment, and the impacts of COVID-19 pandemic and the national lockdowns towards the operations of the community-based organizations. Now, it is a challenge to deliver the services and to operate, to operate like as a community-based organization, to operate and deliver the services to the key population who needs these services. Now, we have invited our country partners from Philippines, Pakistan, Indonesia, to share how they have come up with innovative approaches or creative ideas to make sure that there is continuity of HIV service delivery, particularly on ART supply. First up, we have the Love Yourself, which is one of the partners of the SKPA program. We will be joined by John J.O. Corshega and Dante Corsedino as program officers or program managers of the Love Yourself. And then that will be followed by Muhammad Usman, the director of the Male Health Society in Pakistan, and Irvin Romiko from Linkages in Indonesia, who will share about their program called Jack and Claire to ensure that there is home delivery of ART. And of course, PLF Share and the Red Whistle of the Philippines on AR Bayanihan. So without further ado, let's invite the Love Yourself to have or to share their innovative approaches in order to continue the HIV service delivery. Jo, are you there?
Hi, Ina. This is Danvik.
Oh,
I will
Danvik,
present.
okay.
Yes.
Danvik. Go ahead, Danvik.
Okay, I'll just share my screen.
Yes.
Okay. So good afternoon, everyone. Well, good afternoon from here in Manila. I am Danvik Rosedino, the current Senior Operations Manager of Love Yourself, and I will be presenting in behalf of John Oliver Corshega, the Program Manager of SKPA Philippines, and Dr. Ronnie Vinpakhan, our Executive Director here in Love Yourself. What we'll be presenting is what we have done here in our organization with regards to our response on how do we address the delivery of HIV-related services despite the mobility limitations imposed by the COVID-19 pandemic. As for the information of everyone, Love Yourself is a community-based organization that is based in the Philippines, and we have many clients on our care, I would say. In our normal situation, we are catering around 80 to 100 clients per day per community center, and we have around 6 community centers spread across the Philippines, and we have 7,200 PLHIVs under our care. And since we have this number of clients that um, depending on the services that we are offering in Love Yourself, we simply cannot close our facility, to deny them services just because there is a COVID pandemic. Because still, it's in our mandate is to respond to the HIV epidemic that is still existing up to now. So what we did in our organization is we adjusted the way we operate so that we will be able to provide the services that is expected that we need to give to our clients. So first, our community centers actually did not close even there is an imposed community quarantine here in the Philippines. They remained open for all HIV services that we are offering. However, we are doing triaging system for all of our clients before they enter our community centers. So we conduct temperature checks, mask provision, alcohols in our doors, and all the disinfection procedures so that not only the clients will be protected against the COVID virus, but also us as staff and volunteers that are serving the community. We also resulted into skeleton staffing and reallocation of the resources that we have, since we had some problems with regards to giving all of the services that our clients deserve. So we need to reallocate our resources that we will be able to give so much. We also limited the number of volunteers that are coming in our community centers because we, as much as possible, we wanted to minimize the risk of everyone with regards to the pandemic. However, we shifted to online meeting and planning sessions for our volunteers, and also training and engagement with them, so that we'll be able to still provide the services to our volunteers and still conduct volunteer engagement activities for them. Also for our volunteers, since most of them are stuck in their homes, we still provided volunteer initiatives and opportunities for them so that they will be able to still serve the community. So that's having manning hotlines and managing our social media pages from their homes. So what we did in our community centers is, of course, we had we ask our clients to have themselves self-assessed before they visit a community center, so that they will be able to to minimize the risks of spreading the COVID virus. But also, what we did with the client self-assessment is that our staff and volunteers are monitoring all the hotlines for inquiries. And for those who, when we posted these questions, and if they responded yes, they will be referred to a COVID hotline, so that they will be able to manage. Since answering the risk assessment, if they answered yes, there's a possibility that they are experiencing symptoms that are related to COVID. So what we did for our clients that are accessing treatment, for the 7,200 clients that are enrolled in our care, is that we need to ensure that they are still taking their medication despite limited mobility. So we established a service which we call Express by Love Yourself. So it facilitates requests for ARV refill via deliveries or referrals to our Love Yourself clients. And if there are clients that are not enrolled in our facilities, our Department of Health has released a memorandum so that they could go to the nearest treatment hub where they can access their medication. So we also cater clients that are not enrolled in our Love Yourself facility. The Express service, it's entirely online, and it's manned by both staff and volunteers. And we are sending up to 3 bottles that are sent for delivery, with condoms and lubes that are already included in the package, because we have seen requests from clients that even though that they are still on lockdown, they still need some protective measures for them against HIV. So we still provided condoms and lubricants for each delivery. And if they are under tuberculosis medication, we still provide the medicines that they need to manage their tuberculosis. As of now, there are around 6,604 signups that were received, and we served these clients, and approximately 13% of them are actually indigents. So some of the delivery costs for them were partially supported by SKIPA. We also translated our consultation services online via telemedicine. via our new service called Icon by Love Yourself. So this is where our clients are signing up for a process so that they'll be able to be first triaged by a nurse. And if they need a consultation, they will be referred to a physician if a consultation is needed. So this is a first step for clients that are needing medical consultation. So that includes treatment for PrEP, STIs, and even trans health services, so that they will be able to still receive medical consultations even though they are not visiting our facility. And we have 759 clients that have already been served by this service since we launched it on April 3rd. We also did a demonstration project regarding self-testing here in the Philippines. It was originally stated to be launched April of this year, even without COVID, but because of the demand of HIV testing, especially during this time, our originally slated 1 year demonstration project was just finished for 1 month because of the exceeding demand of the self-care kits. So this is actually a demonstration study that was done by Love Yourself and the University of the Philippines, Manila, with support from SKIPA, WHO, UNAIDS, and Chem Biodiagnostic Systems. So basically what our clients are doing in this service is that they will be accessing HIV self-testing kits via a chatbot, that they will be assisted from the delivery process to the testing process and even the reporting of results. And volunteers are also manning these social media accounts so that our clients will be guided on what to do next, whatever the result is. And of course, condoms and lubricants are also included in each and every delivery. So with regards to the project, around 4,205 clients are interested to join the project, but because of the eligibility criteria, only 2,259 were qualified and 1,689 clients were successfully delivered with kits. And out of those people, 93 were validated reactive, which translates to a 88% reactivity rate. And so far, our linkage to treatment is still ongoing because there are still limitations with regards to public transportation and still limited mobility because quarantine is still imposed in the Philippines. So out of the 93, 55 are already linked to testing and treatment. So for those clients that cannot go to our facilities because there is limited mobility, what we did is that we established Access by Love Yourself. So it's basically an ambulatory service that will bring clients from their homes to our community centers for confirmatory testing, for initiation of treatment, and other services that they need. So it was initially created for self-care clients, but we are starting to expand it to clients who are needing all the tests that they need, and also if they need to be initiated to treatment. So far we have served 22 clients on 31 visits, and we plan to expand it to include a mobile laboratory service for our clients. So for the clients that are coming into our facilities, aside from answering a self-assessment tool, we ensure that our clients all of our sites rather are adherent to physical distancing measures. So what we did is that there is a limited number of people coming into our facility, and we have a schedule mechanism for them, which we call Booking by Love Yourself. So what we did is this service placed a schedule appointment system so that our clinic coordinators will determine how many clients are coming in and how to impose physical distancing measures in all of our centers, so that they and also for our clients, expectations for them is of course to also assess if they have COVID symptoms, and also to ensure that they will be adherent to the services that they need in our facility. The next one is actually we wanted to, of course, education with regards to HIV doesn't stop even though there is a COVID pandemic. So what we did in partnership with SKIPA Philippines is that we have initiated social marketing campaigns that are entirely done online that provides education and awareness to all of our clients and entirely to the general, not only to the key affected population, but to the entire community by providing strategies on how to protect themselves against HIV, or if they have it, what should they be doing for them to manage it. So what we did is that we introduced learning sessions and campaigns and demand generation activities regarding combination prevention strategy, which includes condom and lubricants, the offering of PrEP and PEP, and treatment as prevention, highlighting the importance of U equals U, which is in line with the strategic plan of the Department of Health here in the Philippines. So what we did is that we established the first community-led National HIV Prevention Month. And we actually, the activities are ongoing as we speak. So it's actually a digital campaign, but it has on-the-ground support activities that is done in partnership with 20 community-based organizations in the entire Philippines. So aside from promoting the needs of with regards to combination prevention services, aside from the awareness, of course, we still need to offer these services to our clients. That includes the provision of PrEP under our PrEP Filipinas project. But we established already a telemedicine option last October 2019, but it's highlighted now because of the COVID pandemic. So it's an opportunity for our clients to, to access this service, already established service, so that, their medications will, regarding PrEP will still continue if they are already taking it. And if they have plans to start taking PrEP, it is also done entirely online and via telemedicine. So basically, clients will be enrolling to us, expressing their interest, and the tests will be done with partner laboratories nationwide, and they'll be sending the results to Love Yourself, and we will be delivering the medications to them. Also, in relation to the combination prevention strategy, we wanted our clients to, to assess in themselves what is the perfect combination prevention strategy for them. So what initially started as a condom distribution model, our Safe Spaces project has expanded into a chatbot mechanism where our clients can access and ask so that they will be able to determine what are the best combination prevention options for them. So this is entirely run by chatbots, and there are also volunteers on standby if they want to ask further questions, should they determine the best combination prevention option for them. So aside from, of course, HIV-related services, we recognize that there are clients who are needing resilience, especially during this difficult times. That's why we established Flourish Circle, which is actually a person peer support program, especially for people who have mild to moderate depression and anxiety. So we plan to, this service has already been offered offline via support groups when the pandemic is not yet, on the rise. But because of the limited mobility and the limitations imposed by the quarantine, we transformed the peer support offline to translate it into online support groups and complementary activities that are also part of this program, which includes Flourish 101 talks and art therapy sessions and Flourish Friday playlists as music therapy. So other supported activities by SKIPA during this time is, of course, SKIPA supported community surveys, assessment on self-testing, Filipino sexual health behaviors amidst COVID, and combination prevention. There's also a COVID-19 outreach that was done in Cebu City jails, and we also conducted a Rise as One online concert in honor of the COVID and HIV frontliners here in the Philippines. So also, what we did is that in collaboration with other community-based organizations in the Philippines via the Champion Community Center Network, we have active collaboration to amplify and localize online support marketing initiatives. This network of community centers are ready to scale up HIV innovations and replicate Love Yourself's delivery differentiated care approaches. And SKIPA Philippines is here to support the online community system, strengthening modules for a new cohort of community-based organizations that wants to become a part of the Champion Community Center Network. So basically, that's it. Those are just some of the services that we're doing right now here in Love Yourself here in the Philippines. And we hope that all of you are safe. And we hope that we will not return to a new normal, but basically we are looking for that time for us to have hugs and basically, for us to return to basically what we have been doing before. But for now, we're sending all the virtual hugs to everyone. And thank you so much for listening to our story.
Thank you so much, Danvik. And send our best regards to Jo and Mama Vin. And keep safe in the Philippines. The COVID-19 cases are rising exponentially. We are now reaching almost 150,000 cases.
So the reacher basically, we are working basically on working on controlling and prevention of HIV/AIDS and STI, specifically for the sexual and gender minorities across in Rawalpindi, Pakistan. So we are basically working on the service delivery. We are working on the advocacy. We are working on different other things like distribution of ARVs, distribution of PAP and PrEP, and advocacy with the other stakeholders. So, if COVID basically affected all the community in Pakistan as well, like as it affected in the across the globe. And basically, but in Pakistan, though the community is quite marginalized and the country economic situation is quite low, than as comparatively comparatively with other countries. So the situation was quite bad. In the start, there was a complete lockdown imposed by the government, and law enforcement agencies basically were not allowing us to open our offices and to do any kind of operations. But definitely after that, we were receiving different messages from the community that they were lacking for the food, lacking for the medicines because they were getting ill. Though it was not the COVID exactly, but the symptoms were leading towards that. So basically, that might be some other thing, but the community was texting us because they were mentioning that the corona might not get affected us, but we might get basically infected by the hunger. So there was a gap in the start. Then we have started our service delivery again, and we were distributing condoms and distributing and food packs and the PPEs across the whole area. And we were basically unable to interact more and more community members in that time, but definitely we were trying hard. So now this is the situation. Basically, we are fully successful in covering the whole area. At that time, there were problems to get the ARVs. Basically, there was a problem to get the ARVs on time from the government hospital, but people were stuck in those areas. Where the complete lockdown were imposed, and the few areas were basically sealed by the government due to coronavirus infection. So the prevention at its lowest, I would say, at that time. And then definitely psychological issues were there within the community because they were unable to go outside, they were unable to go anything like the main. Let me tell you that the main work of the community in Pakistan is sex work, begging, and the entertainment functions. All the things have been stopped. So there were a lot of problems. Then definitely there were few interventions which we have taken basically with the help of national and international donors. We were basically uh, we were distributing different PPEs among the community. First of all, definitely safety comes first. Then we have started distributing condoms, distributing ARVs, and especially PrEP as well, just because community started sex work again, just because they were unable to survive themselves, because in one area, in you can say in one room in a building, a lot of more than 8 people were living. So that was a quite bad situation among the community in Pakistan. So the Richa at that time was there to mobilize the people that they can contact us. Our team was ready to go anywhere in any area to provide the services. So definitely at first definitely we were unable to provide the services. Then after 20 days we have started the services again. Then we were successful in providing the awareness sessions on COVID, HIV, and then PAP and PrEP. Then we have taken the initiatives of counseling as well, which was mostly on call for the community. So they were like, if the community is unable to call us, they can text us, they can buzz us. So we usually call them back after whenever the counselor and the paramedic staff gets free from one client. So we usually call them, we usually counsel them regarding their depression, regarding the COVID, regarding HIV. We usually try to solve their issues. So that was basically the interventions which we have taken. Then definitely we had the lessons learned from the community as well, because in that time, that was the first time I think the pandemic taken over. So in this time, we were not having funds to meet any kind of emergency. Like, what about the nutritional plans? What about the ARVs at the doorsteps? What about the PEP and PrEP? So it's okay. In the pandemic, there were very less cases of PEP, but after 20 or 30 days, there were the cases of PrEP. So we were there. Basically, we have learned a lot from this pandemic, that these are the issues, these are the pandemic. In these kind of scenarios, we do have the funds to meet any kind of emergency. We had to have some kind of nutritional plans for all the PLHIVs through CBOs, because for all the clients, it's not possible to go into the recent government hospital, and most of the community members do not go to the government hospital just because of I would say discrimination and stigmatization. And these are the things basically which the community have to face in the government hospital and or the government designated area. So they prefer to come into the CBOs. So that's it from my side. Thank you.
Thank you, Usman. That's from how the key populations or the communities have adjusted from the effects of COVID-19 in the country. Now we're proceeding to Indonesia, where our partners from Linkages Indonesia will be presenting their program called Jack Anted in delivering to the homes of antiretroviral therapy. We welcome Irvin Romito from Linkages to proceed with your presentation.
Thank you, Enoch. Let me try to put up the slide first.
Yes.
Is it up?
It started screening. I started to share. Yep, go ahead.
Okay. Okay, hi everyone. I'm very pleased today to represent Linkages Indonesia and to provide a short overview of the Jak Antar initiative in Jakarta. So as an overview, Jak Antar is a home-based ARV treatment delivery platform to ensure sustained and safe access to HIV treatment among PLHIV during COVID-19. My presentation is divided into three main parts. So the first section provides a quick overview of COVID-19 in Indonesia and describes how COVID-19 is making it difficult for PLHIV to stay on ART. Later on, the sections describe the Jak Antar and the steps we put in place to implement home-based ARV delivery in Jakarta. And the final section outlines some key results of the initiative and the next steps towards institutionalizing this important intervention in Jakarta. So to start, let's look briefly at the COVID-19 situation in Indonesia. Unfortunately, the country has the highest number of cases in Southeast Asia and records the highest number of deaths. Cases continue to rise, as you can see from the graph, and within Indonesia, Jakarta is one of the hardest hit areas. Pre-COVID, Jakarta was providing treatment to over 25,000 PLHIV, of which 17,586 received ART at 60 sites supported by linkages. After the national state of emergency was declared on March 20, the Jakarta governor introduced a large-scale social restrictions, or so we call PSBB. This restriction closed schools and entertainment venues and limited people's movement. Health facilities also changed their operating hours and the services they're offered so that they could better respond to the COVID-19 crisis. At this time, providing support for PL-HIV became difficult and became even harder as ARV supplies ran low. Interventions like 3 or 6 months ARV dispensing were just not possible. The second section, we are talking about ensuring treatment continuity for PL-HIV. So together with our government, facility, and community partners, we realized that we needed to act quickly to help PL-HIV stay on ARV by policy to practice, providing 2-month ARV, and introducing Jak Antar. So as you can see here, our first step was shaping policy. In March 2020, we helped the Jakarta Provincial Health Office introduce an emergency circular letter that included provisions for 2-month ARV dispensing. And for the first time, the home-based ARV delivery service. I want to talk about, then we went about creating a home-based ARV delivery system. Because community-based case managers could not travel during the PSBB, we could not ask them to deliver ARVs to PL-HIV clients. Instead, we had to rely on ride-based apps like Grab or Gojek and courier services. We also needed to create an SOPs, as you can see here on the picture in the center, to ensure safe and secure delivery of ARVs from facility to client. And we ensure the privacy was maintained and that the medication packages were discreetly wrapped, socialize the healthcare providers and PL-HIV about this service to get their buy-in and support, develop simple monitoring tools to track delivery service uptake and payments, and ensuring USAID concurrence for supporting home-based delivery payment. So very simply, Jak Antar operates like this. First, a client who is unable to come into a facility for services due to COVID-19 restrictions has their address and mobile phone number confirmed by the facility staff. And then the staff member contacts the client to confirm that their location is suitable for receiving ARVs. The ARVs and then sent to the client through the Jak Antar delivery system via a ride-based apps or a transport courier, such as Tiki or JNA or Grab or Gojek. And then the client confirms the receipt of the delivery with phone message, photos, or WhatsApp correspondence. And finally, the ARV home delivery information is collected and processed by linkages. So on the last section, I want to talk about, we have been supporting Jak Antar intervention for 3 months now. And I want to share with you about some initial program results and next steps. As you can see on the figures, it shows both 2 months dispensing and home-based delivery coverage has risen exponentially since March, with 9,539 or around 69% of eligible PL-HIV receiving 2 months ARV at 60 linkages supported sites. And on the right side figure, you can see 4,498 or more than a quarter of PL-HIV at these 60 facilities receiving home-based ART services. And what about the costing? For 3 months, total cost of 3 months provision supported by linkages is about 3,281 USD. And total patients of the Jak Antar supported by linkages is 1,898. So the average cost of the Jak Antar per delivery per month is about $1.7. Look, I just want to share with you on this slide, best of all, both service providers and clients greatly appreciate the service. From the healthcare provider, their workload decreases and they can focus on other key tasks, including COVID-19 tracing, and from the client side, help them to stay on HIV treatment and lower their risk of COVID-19. So what is the next step? Of implementation were enough to demonstrate the intervention efficacy to our partner, PHO, which is now putting parameters in place to institutionalize home-based ART delivery into longer-term policies. Linkages is also in the process of expanding this service across all Jakarta treatment sites and is undertaking more rigorous monitoring to assess its effectiveness in the months ahead. I think that's it for the presentation. Thank you for your attention.
Thank you, Irvin. So if you have any questions to any of the speakers, please feel free to type in your questions. The next speaker will be from the Philippines, and I will be sharing the screen for TLF share. Oh, no, that's not.
Yeah, that's it. That's it.
That's it. Okay. Cool.
Thank you. Good afternoon. I'm Anastasio Marasigan Jr. I am the Executive Director of TLF Share, a non-government organization working on HIV and AIDS, human rights, and capacity building. So what I'm going to share with you is actually the response of HIV AIDS CBOs, Philippine-based HIV AIDS CBOs, with regard to the pandemic, specifically the Arbayanihan. So I'm going to do this presentation together with Ben Bernabe of the Red Whistle. So let me present to you first the context of where we're coming from. No, so next slide, please. So uh, last March 15, the government decided to impose enhanced community quarantine, wherein it placed 53 million Filipinos under ECQ for more than 90 days. Again, probably already know that Metro Manila is back to the modified enhanced community quarantine. So Luzon, the major island of the Philippines, was placed under quarantine for more than 90 days. So 53 million Filipinos were placed in quarantine. Next, please. Days prior to, next, please, thank you. Hello? Next slide, please. Thank you. Okay. Uh, Days before the quarantine, there was a massive exodus of uh, people. Okay, there was a massive exodus of people from Metro Manila to nearby provinces and regions. Um, and because of the quarantine, no public transportation was allowed. Business, factories, and companies ceased operations. Schools were suspended, like similar to other countries in Southeast Asia, and most government institutions went on partial shutdown or temporarily closed. So even the clinics, hospitals, small clinics that are not catering to COVID patients were asked to cease operation, and a lot of the personnel were asked to to assist in the COVID response. Next slide, please. Thank you. So now, the question that was raised immediately after the quarantine was imposed, especially from the PLHB community, what's going to happen? There were a lot of anxiety, uneasiness, uncertainty during the first week of the quarantine. Now, there was a survey that was conducted, and based on the survey, was done, has come out with a more systematic of knowing what the sentiment, what the concerns of the community. If you're going to look at the result of the survey, you would notice several items there, and there are three major concerns that came out. The first one, 66% of the respondents said that their major concern, especially among PLHIV, their major concern was about transportation, mobility. Second place, we have two items or two information here. The location of the treatment hub, and of course, connected to the location is of course checkpoints and crossing borders, because there were a lot of PLHB who were displaced when the lockdown was imposed, and there were a lot of PLHB who decided to go home to their respective provinces, to their respective regions. The main concern of PLHB, especially those treatment hubs, were in Metro Manila. Their main concern was how to access their treatment hubs if they are 40 miles away from the capital. So, and every time if you have to travel, you have to have a very clear explanation as to why you're traveling. You have to have the necessary papers why you're traveling. And a lot of the people at the time were very much afraid of disclosure. They might be disclosing unnecessary disclosing their status. They're afraid that they might get discriminated once they are at the border. Number three, based on the survey that was conducted, of course, the issue of the ARV, the stocks of ARV. Remember, um, a lot of the PLHAV were not anymore in Metro Manila. There were a number of PLHAV not anymore in Metro Manila. So they were basically quote unquote being accommodated by the regions, by the provinces. But these provinces, these local areas where they are located, uh, they have they only have ARBs specifically for PLHAV enrolled in their center. So if you are from Metro Manila and you decided to go to another area, you are not, you are your needs are not part of the inventory. So that was really a major concern of the community. And another thing I'd like to highlight in this is the 41% actually they were concerned about financial assistance, because a lot of them lost their jobs. A lot of them, again, like what I've said, decided to go home, and they don't have enough, savings to tide them over the next coming months. Next slide, please. Okay. So now, given the scenario, these are the so-called stages of response. The first was the pre-lockdown preparation. For example, TLF, my organization, prior to the lockdown, we've already started developing the COVID-19 response or protocol or operation. So again, taking into consideration the COVID-19 situation, we decided that we have to change the way we operate. But at the same time, we have to take into consideration that there should be no disruption in terms of delivering services, engaging the clients, engaging the community, but it must be based on a certain guideline, based on a certain protocol. So what we did, we used the data and the government guidelines in crafting the protocol of the organization. Even as we speak, we are still updating it, because the situation in the Philippines is still evolving with regard to COVID-19. Now, when the lockdown happened, these were some of the actions that we have undertaken. The first action that we did was to do a quick response, to immediately address some of the concerns of the community. Again, no, like in any disaster and like in any crisis, um, this is the first action that that you usually do. So we asked the community members, what are your concerns, what are your problems aside from ARV. Some of them said that they don't have food. Some of them, for example, some mothers expressed the need for milk, so diaper. So those are quote unquote immediate concerns that we as an organization and with partnering with other organizations decided to deliver, because again, those are immediate needs, or those are really quote unquote immediate concerns. The second point, mapping and survey. So we had to map. We have to conduct a survey. We have to gather data. So mapping, who are the communities, who are the organizations, who are uh, the CBOs that can be tapped, that can be assisted, that can be can be a partner. And at the same time, we have to start gathering data. We have to have, aside from anecdotal reports, we have to have concrete data. That's why a survey came out, and this survey was developed together with UNDP. Now, we have a lot of networks in the Philippines, and we saw the need to mobilize the network. So one of the networks that we tapped, the N Plus, NSAP, Dangal Filipinas, and other networks. But these are the 3 or 4 networks that we tapped into, because we know that this network, they have direct connection with the community. They know their clients. They know the people in the ground. No? And aside from that, again, no, very clear from the very beginning that we have to have a protocol. There must be a guide. There must be a system in terms of how we're going to deliver, how are we going to monitor. That's why we develop a protocol, an algorithm that that can be used later on. That will be used and later on can be updated or developed. Another component, again, partnership. Usually, when you talk about partnership, it's just between the government. But this time around, the partnership is among NGOs, among CBOs. In fact, we even entered into memorandum of agreement so that everything will be in black and white. That these are the deliverables. These are the things that we can actually do for one another. So there was this very clear agreement that that we are committed in terms of providing the necessary services that might be needed by the community. So last one is mobilization of resources specifically for far-flung regions, because Metro Manila, yeah, Metro Manila can basically, there are a lot of NGOs, CBOs in Metro Manila, but the question is, what are we going to do with far-flung regions or areas? Because these regions, these areas, they don't have Grab, they don't have alternative mode of transportation. So, uh, what happened? We tapped into the AIDS regional coordinator. So we tap into the AIDS regional coordinator, and this AIDS regional coordinator, they were the one who started mobilizing again the community and delivering the medicines, delivering other, aside from medicines, delivering other essential needs and goods. Now, one of the things that we realized in this response, in this situation, is the institutionalization of what we call surge response capability in crisis situation, because CBOs and non-government organizations are not used to this kind of situation. It's not part of our DNA. It's usually we rely on the government to respond to the crisis. So again, the surge response capability is something that we realize that we have to start developing among ourselves, that every time that there is going to be a crisis or a pandemic, we know what we're going to do. Search response capability is tapping into the strengths of our own organization. If our own organization is strong, capable of social media, volunteers, etc., when a crisis happens, you increase the capacity, you increase the capability of your social media, your volunteers, so on and so forth, your clinics, etc., etc. So we believe that there's really a need to institutionalize search response capability. And one of the things that I think that came out of the sort of an opportunity that came out from this pandemic is, of course, the story of the Arbayanihan. Next slide, please. So the Arbayanihan, I'm going to give the floor to Ben Bernabe of the Red Whistle. Ben, thank you.
Hi everyone, and good afternoon. My name is Ben Bernabe, and I'm from the Red Whistle. I'm going to share my screen. If I can. Ian.
Are you going to share your screen?
Can I? Yes, please. Thank you.
So if I could request you to, for the interest of time.
Yeah, it's going to be 5 minutes. I time myself, don't worry.
Okay.
So hi everyone. So the Red Whistle is a nonprofit organization in the Philippines, and our Bayanihan is our emergency ARV refill delivery service. So we were featured in the UNAIDS website on April 8, 2020, highlighting the community-led mechanism that we created among the networks and the organizations that Tasing has already mentioned. So our Bayanihan is a portmanteau of two words. So ARV, we all know what that is, and the Tagalog word Bayanihan, which means being a hero for each other. It is a volunteer-driven and ARV refill delivery service, and it's currently funded by UNAIDS Philippines. So the first iteration of our Bayanihan is a map. When we had our enhanced community quarantine, or level 4 lockdown of 4 levels, so this is the strictest one, we had to check if the hubs are accessible to people, and we saw that there are many gaps in many areas. So this is Metropolitan Manila area, and if you look at this map, you can already see 1 kilometer and 2 kilometer buffer zones around each treatment hub. We are assuming that people would be willing to walk up to 2 kilometers, but it actually takes an hour to do a 2 kilometer walk in Metro Manila, past the checkpoints and everything else. So what we organize are volunteers of individuals who have cars, and we arranged for classes for them, travel authorities in partnership with local treatment hubs and local government units. And what we had was we were able to assist around 596 people living with HIV all over the Philippines during this lockdown phase from March 5th or March 16 all the way to April 30, 2020. The current phase is being sponsored or funded by UNAIDS. So what we're doing now is we tied up with Angkas, which is a ride-hailing app using a motorcycle. And right now we have assisted 494 people living with HIV in the National Capital Region of Metro Manila to date. Angkas is only available in Metro Manila. So what we do is we continue to provide volunteer-driven vehicles in regions outside of Metro Manila. And we are also now reimbursing courier expenses. So it's pretty similar to what Indonesia does. So they use the app of Angkas to order a delivery service, and we provide them a promo code which removes any costs from the delivery. So this is available to any person living with HIV within Metro Manila, and the pickup points are specific to the treatment hub locations. So you can only use it for delivery from the treatment hubs. So this is our project, and it's a very simple partnership of different kinds of organizations, CBOs, UNAIDS, and a private sector organization to assist people living with HIV in getting their ARVs delivered to their doorstep without having to leave the house. That's it from me.
Thank you, Ben. And for the interest of time, we are jumping right ahead to the next presentation, which is from Michael Castle.
Thanks, Anad. Are you able to help share my slides?
Yes, I'm just looking for your slides.
Thanks so much for that. I really appreciate it.
No problem.
While you're putting them up, I just want to say thanks so much to APCOM and to all for the opportunity to learn from everyone's experiences, to share some of these resources that I'll share that we've been collaborating with UNAIDS and others to develop on mitigating the impacts of COVID-19. And also on a Friday afternoon to say I just really miss everybody and engaging with this really supportive and compassionate community. Even just registering for this event brought a smile to my face, seeing that caring question about how COVID has affected you. And I think the answer probably for most of us is in every possible way. So I wanted to appreciate that.
Okay, I found your slides and I'm putting it on screen.
Great. And if you're able to just maybe go ahead and jump to the second slide.
Okay.
Great.
Is that
thanks.
the correct slide? Okay, correct.
Yeah, thanks so much. That's great. So really, I think I was just asked to share some resources that the Global EPIC and Linkages programs have put together. So I will try to do that very briefly. I guess I wanted to just highlight thematically, since this session is on the way forward, some of the things that we were struggling with as we were putting together these resources. So as others have noted, it's really hard to find an upside with COVID. It's completely disrupted everyone's lives, our work, our health, our relationships. But as we were working to develop some of these materials, this disruption caused us to shake up our thinking a little bit about the response to HIV in perhaps some constructive ways. We aim to embrace a mindset that every challenge is an opportunity, and to consider whether at least some of the challenges imposed by COVID-19 might be constructively disruptive, providing critical opportunities to advance HIV policy and practice. And I think Anna and others have alluded to some of these opportunities. And indeed, I think that some of the challenges imposed by COVID on HIV programming highlighted some of the issues that we've all been facing anyway in terms of closing gaps to address differentiated preferences and needs of individuals who are being left behind in the HIV response. So in a sense, it became increasingly clear to us that there's still a need to shake up the status quo to engage those for whom current solutions aren't working even prior to COVID-19, and a need to empower clients with new options for access to overcome COVID-19 related and previous barriers to care. So with this in mind, we wanted to start with just putting together a framework to guide some of our thinking and our action. And that's what you're seeing on this screen right now. We really wanted to put this goal of continuity of HIV testing, treatment and prevention for PLHIV and for KP at the center, while also minimizing COVID-19 exposure risks, and then thinking about sort of a three-pronged strategy that really focuses primarily on safeguarding providers and beneficiaries, particularly from COVID-19, and then supporting safe, sustained HIV service connections, and then also really focusing on using data and experiences to monitor and improve client outcomes, recognizing the need to tailor services and approaches to differentiated needs at the individual level, at the site level, as part of a differentiated service strategy. So if we go to the next slide. So with this framework in hand, I'm just going to walk through some of the materials that we've created, and there's a link at the end to connect you to some of these. We started off recognizing that as much as we had these broader aspirations, the big key emergent priority is protecting and sustaining the gains that we've had so far in the response to HIV. Globally, 2/3 of 38 million people living with HIV now know their status and are accessing life-saving treatment. It's taken us decades.
Michael?
Hello, Michael.
Michael? Michael, are you there? Oh, let's wait for Michael to come back. I think Michael has dropped off from the group. I think while waiting for her to come back, do you have any questions that you want to raise in any of our previous speakers? So we have had a lot of information from International AIDS Society, Anna, from Dr. Fatim Ifeo, and from our community-based organizations. Oh, Michael, is Michael back?
Now?
Oh, okay. So
Can you hear me now?
yes. Yes.
So where did I leave off?
So you were talking about the links or the available resources for moving forward, and you were talking about the strategic considerations.
Yeah, okay, great.
Yeah.
Thank you so much. So literally what just happened, and respecting time, I'm gonna move ahead and not backtrack, but literally what just happened is a cat sat on my microphone and unplugged it. So that's the world that we're living in now. Sorry for all of that. Let's jump to the next slide in the interest of time, because I know we're behind. Okay, so in addition, we recognized that it was important really to prioritize safeguarding of caregivers and providers, both in community and clinical settings, that if we couldn't care for and protect caregivers, then we couldn't ensure continuity of services. So we have two materials here. One focuses more on community-based providers and another more focused on clinical settings that are really focusing on primarily safeguarding, but also ways to sustain services. So that's virtual training, capacity building and support, including stress management and other kinds of support for caregivers, protecting providers with PPE and other strategies, moving engagement and case management online as much as possible, hotline support and virtual navigation. Again, I think one of the things that we identified as a challenge is that under COVID, one of the key principles is that it's important to keep sick people out of facilities and figure out ways that we could actually provide treatment outside of facilities, because ironically, bringing them into facilities could potentially just create more illness. And so figuring out strategies to do that. And then, as I mentioned before, tracking progress and pitfalls down to the individual level if possible, just to try to make sure that we're really addressing people's needs from a client's perspective. And if we move to the next slide. And then I think this may be the most useful to folks material that we had generated so far, really messaging guidance. And you can see the intended audiences depicted here. But the idea was that we had, and I think we all share these concerns, that a lack of information or misinformation can be paralyzing and prevent people from accessing needed services, whether they be HIV services, COVID-related services, mental health services, or other services. And so it was really important for us to sort of incorporate messaging guidances that clarified what we currently know about COVID and HIV, and help to provide some provider and client-facing information and survival tips for staying connected. So how to seek remote dispensing, how to advocate for yourself in terms of being able to access services and self-navigate services, those sorts of things. So those are in this document. And the topics that are covered are multi-month dispensing, PrEP, self-testing, inquiring about virtual services, addressing needs to address gender-based violence as people are increasingly at home and at potentially increased risk due to travel restrictions, and certainly the importance throughout of mitigating stigma and discrimination. So if you move to the next slide, everyone will be pleased to know that that's it. Here's a link to the materials. I do appreciate that we're behind in terms of time. I know this session was supposed to focus on the way forward, but I think we've highlighted some interesting themes that maybe we can talk about in the chat. What are some of the COVID-19 related HIV solutions that we want to carry forward past, hopefully, the end of COVID-19? And then what are the service delivery lessons we can take from HIV for COVID-19 and vice versa? So thanks very much for your time. I'm sorry I dropped out. My cats also apologize, but great to talk to you all.
No worries, Michael. And thank you very much for sharing those information, and please say hello to your cat. So we do have some questions here. I know we are behind of time, but we can still extend a few minutes more. But one of the questions that Richard has typed in, can someone share programs that describe access to HIV testing practices during the COVID-19 pandemic, especially for areas where HIV self-test kits are not available? Or do we have data on that kind of information? Anyone? So the question is about HIV self-test kits, HIV testing practices, particularly on self-test kits. So someone from Indonesia said they provide self-test kits in Angsa Merah medical health program that help field officer in the outreach. So are there any other practices? Because I think the most important question here is how do we then make sure that HIV self-testing will be included into the HIV program, and making sure that HIV self-testing is approved by FDA or funded by national programs or PEPFAR in the next few rounds, in the next few years. And then there is also a question about in all of these community-led responses, this particular person is interested to know what is the extent or level of engagement that the ministries or the departments of health and government in terms of providing comprehensive support for ART in delivery in their respective countries. I think I can just share that. Okay, so I am just putting all the questions in the Word file, and then I'm going to share it to everyone. Share screen. Okay, one of the questions in all these committee-led responses that this particular person is interested to know what is the extent or level of engagement that the ministries or departments of health or governments in terms of providing comprehensive support for ART delivery, if there is any. And someone's wondering if there has been any anecdotal reports of an increase in alcohol and drug use amongst the communities during the period of lockdown, I suppose, and what support has been provided to those who have requested it. I think these questions. The first question will be directed to our community partners from Love Yourself, PLF Share, Linkages, and Dericha. Muhammad Usman, would you like to address that question? You can unmute your mic, yeah?
Yes.
Yeah.
Say that here, during the pandemic, there was a quite bad situation, as I told you in my presentation, regarding the delivery of ARVs and as addressed by some of my friends regarding the ART delivery in my respective country. Later on, with the help of government of Pakistan and WHO and different other departments, we have established the helpline numbers, toll-free helpline numbers for all the community to get themselves registered with the government of Pakistan, so they can get the ARTs at their doorstep. So we have done that. Basically, we were connected with the community. So we at the REACHA, basically we were calling each and every client who have been diagnosed in the past 3 years. So I mean, not only in 3 years, the clients who have registered with us since 8 years. So we were calling each and every client with the help of counselors, clinic department, and outreach workers. So we were calling myself, even I was in contact with the clients. So with all those clients who were unable to get themselves treated by the government hospitals. So we were quite able to deliver most of the ARVs at their doorsteps. A few of them were able to get themselves at the government hospitals as well.
Thank you, Usman. Okay, I think
Inad,
yes.
can I share something?
Of course.
Yeah.
Please go ahead.
Okay. With regard to the Philippines, when the ECQ was imposed, hi Emily, it's nice to see you again. With regard to the Philippines, when the ECQ was imposed, there was a liquor ban, so access to alcohol was really very limited. But again, the more critical issue here is about drug use. No, again, the war on drugs of the government continued, and still, at the same level of intensity. In fact, during the ECQ, there were still a lot of uh, there was still a lot of operations that happened against the use of drugs, and based on discussions in from the community, there are a lot of people who are using drugs or who are now on quote unquote experiencing withdrawal, experiencing looking for drugs, and that actually placed them at risk because they would really try to defy the quarantine, would try to defy the curfew, no? And some of them have resorted to using a Grab or Lala Move. Those are alternative delivery transport, and there are reports that are actually the police are now looking carefully into the delivery of goods and services because these are now actually being used as part of the trade. No? So again, because of the lockdown, they're stricter and there are issues of withdrawal, and they're also drug PWID who are now experiencing, like what I've said, experiencing withdrawal, and they're really becoming more quote unquote in terms of behavior. They're defying the lockdown, the quarantine, so they're more at risk right now and vulnerable.
So I think that there are two key populations that we're talking about here. First one are the people who inject drugs and the MSM who engage in chemsex, and that those two have different motivations on drug use. And we were just on the other webinar the other day where there is still no current data on the increase of drug use among MSM who are engaged in chemsex during the COVID-19 pandemic, and I think this is a very good opportunity to kind of like get that information. In relation to people who inject drugs, I guess the main issue is their access to treatment. particularly the methadone treatment in the countries where there are national restrictions on mobility. So please have your questions ongoing, and for the interest of time, we will be summarizing all these questions and share it to everyone who has registered. We all have your emails. We will be sharing, of course, with the consent of the presenters. We will be sharing the presentations for you, for your references. And we are continuing these discussions in the next webinar. So this is just the first of the 3 webinar series that APCOM, with the support of Linkages, is organizing. And the second webinar is the most important one, I think, because it is where we define the roles of the community in response to COVID-19 and how do we integrate the COVID-19 and HIV programming. There's a question from Mongolia. Thank you, Bill, for this question. How do we make Global Fund understand the situation in every country, that we are not going to reach out, or we may not, because of the national lockdowns, we may not be able to gather key populations or our community members for a particular event. And IIS is providing us with a lot of references. So we are going to, us at APCOM, we are going to collate all these references, and we are going to include all the sharings in the group chat in a document, and we will share it with everyone. So I noticed that some people from Vietnam also shared their experiences in HIV self-testing, also in Indonesia, and we will make sure that this information we will send it to you by email for those who has registered. It's very good to have this kind of conversation and have a very Asia-Pacific focus on the impact of COVID-19 to community-based organizations. And I very much, I extend my appreciation to International AIDS Society for providing the information that we need, to Australian AIDS Federation-based organization, to Linkages and EPIC, and of course, most especially to our community partners from the Philippines, Indonesia, Pakistan. Thank you so much